talk is on visual function classification system. I would take you through that. Okay, my slides have frozen actually. Okay, so need of visual function classification system. Why was the need to have this VFCS classification? So the incidence of visual problems in cerebral palsy is being reported to be about 68% by IJO, Indian Journal of Ophthalmology, in 2007. Strabismus being the commonest problem seen in CP children in India, about 38 to 50%. Globally, they have reported about 50 to 70. CVI is also being seen as a global incidence of 60 to 70, but in India, it has been 9 to 54%, depending upon various studies. Refractive error about 25 to 38, optic atrophy about 5.5 to 11%. So all these problems are easily picked up in an ophthalmic office, but there are certain problems like functional vision, which are required for day-to-day activities, usually gets missed. Now, this is so subtle, which we take it for granted, like the typical child would take it for granted, like differentiating between the objects or identifying the toys. So all these things becomes difficult in a child having problems, visual problems in cerebral palsy. So this includes altered fixation, peripheral field of vision, abnormal contrast, stereopsis, abnormal saccadic and pursuit movements. So in order to provide better rehabilitation of a patient with CP, a valid tool classifying how children will use their visual abilities in daily life is created. It was done by Baranello et al., a group of specialists in Italy, and it was recently published in Developmental Medicine and Child Neurology Journal in 2020. So it's relatively new, and even I am in the process of using it. We have not used it completely. And a very interesting point in this was that they included the patients with CP and the parents of CP. So they got the first-hand information from the patients and patients themselves. And thus it helped in validifying the VFCS. So what are the salient features? All the levels in the VFCS classification is based upon WHO ICF activity and participation concepts, and not on anatomical or pathological disorders. Sorry. Okay, it is a 5-level classification, level 1 being the best use of vision and level 5 being the severe limitation in daily activities. It was validated for the age of 1 to 19 years. It can be done by anyone familiar with the patient. So it can be a teacher, a parent, a therapist, caregiver, anybody. It is not an assessment tool, does not explain the reasons of visual function disability, like why they are behaving that way or why the ability is decreased, but it highlights more of the ability and not disability. And it describes performance in best conditions, means in a given situation, how the child is responding to that situation. And it does not mean that child is not able to or does not have the ability or the capacity to improve further. That would be on subsequent observations and assessments and training. So this is why it is important to think about daily situations in typical environment which the child is used to, like the daily everyday environment that they use, while classifying the level of visual functions. So how is it useful? See, it is an easy method for stratifying the visual function of a child with CP, and accordingly we can plan the interventions which is needed further to push their functional abilities to better levels. It can also be used as a tool for communication with parents to tell them that where their child stands and how they can do better with further training. It can also be used for interpersonal professional communication, that a occupational therapist giving occupational therapy would know, okay, the visual functions is at this level. So this also provides a better rehabilitation strategies overall. It can also be used for research purposes, whoever wants to plan a research study further. So I would just brush through the level of VFCS and then we would take it in detail. So the first level includes the best level, which means it is an easy and good use of vision. The child does not struggle much to use his vision. And sometimes in new environments he may take some time, but readily adapts to the environment without having any modifications to be done of the environment or doing any self initiated compensations. So now this takes us to level 2, where the child is using vision consistently, but with a lot of self-initiated compensation. So the child has that intelligence to understand that if I may tilt my head or if I do some other compensations, I would be able to see more better. Third, in this, we need to help the child by providing environmental modifications. So, third is using vision in most situations, but with adaptation strategies which have to be provided by the caregivers. Level 4, it can use vision in highly adapted environments, but it performs only part of the vision activities, and it is supported by other sensory modalities like tactile cues and auditory sensations. Fifth, whatsoever you try, the child is not using the vision. So we will see each and every level in detail. Let's see. So first and foremost, before we start the levels, what you would have to see is the use of vision in daily activities, like in the play area or in the communication area where they are communicating with the parents or the child or the caregiver. Typical and familiar environment is more important to better understand the child and stratify accordingly. There's no there's no testing, it is more of reporting, like seeing and reporting. There must be differentiation between added stimuli with sound and touch. All the observations have to be done with corrective glasses, if any. So refractive error correction is very important, because otherwise we won't understand whether the child is not seeing due to loss of interest or other visual parameters which are affected, or the child is not able to see because of the refractive errors themselves. Now, what we have been talking about visual function on all these slides, but what does it mean? It includes all the vision related abilities of an individual, where it could be because of peripheral impairment, that is ocular, the eye, or it is coming straight from the brain. So cerebral vision impairment. And visual ability, the definition includes purposeful use of vision to see, which means fixate, direct gaze. Okay, so following or tracking of the objects, recognition of the objects faces, or even day to day the environment which comes into the flow, interaction with the environment, and exploration of an environment. So this is an example of level 1, where the child is comfortably seated on the mother's lap. The therapist is trying to show Leah paddles. So it is a preferential looking test to test visual acuity in a child which is pre-verbal or not gone to school yet. So this is an image of the different Leah paddles. It is a black and white strip giving the highest contrast, and the black and white strips decrease in width, which means the visual acuity is increasing, further tested. And in this example, in this picture, the child is nicely looking at the paddles, trying to follow the paddles, so which is good as per her age. One more example, this is an older child, so it is an unobtrusive observation, which means like this is a new or crowded environment. The child is being sent to the therapist for checking whether the child has any problem, and so the environment is completely new. There are also other children around where he interacts with the other children. So in this environment, the child may take some time to adjust, but will soon learn to use the visual functions. And there's no need of environment changes to be done by the therapist, or no other cues required. Slowly he learns and he adapts to the new environment at that moment itself, or in that scenario itself. So this is a good level. Level 2, it's self-initiated adaptations. I was listening to the talks before, the cards before, and there were talks about head posture. So if it is not related to any contractures or anything, you would be amazed to see how vision problems could lead to these head postures. So that will be my next slide. What are the other initiated what are the other self-initiated adaptations? It includes like finger pointing to explore complex images. So if there is a crowded environment, the child purposely points at certain things, so a certain object or a face, to magnify it in their brain and to focus only on that object. Also, adjustment of an object to comfortable distance for best focus, placement of an object in a special visual field, as children with cerebral palsy suffer with visual losses, especially the lower field vision. So the next slides are the example slides, which will make you understand and why all these adaptations are done. So then there is a better localization of visual targets and also helps in improving the eye movement quality. So this is a self-initiated adaptation. On the right, it's a Snellen's chart. The child in this video is not a cerebral palsy child. The child has nystagmus, but we will try to see how he's initiating and initiating an head posture. And same way, a child with CP having squint or any visual field losses or nystagmus would adapt an head posture. So let me play the video. So if you see the eyes are moving. It is a horizontal jerk nystagmus. And he's trying to read the chart away, which is at 10 feet from him. So he's reading the first 3 lines with his head straight, the 660 to 624. Now he's finding difficulty and he's telling me that, ma'am, I'm not able to read. So he shifts his, so he adapts his face turn, like he adapts a face turn to the left. So there he reaches a null point of nystagmus. You would see the movement of the nystagmus is decreased. The movement of the eyes is decreased, the frequency and the amplitude, and this results in better visual acuity. And then he could read to 612. And once he read up to 6/9 parts as well. So these are the self-initiated adaptations which you should look in the clinic in a patients with CP. Then one more example. So this child is a very curious child, and he wants to read everything which is provided next to him. So what he did was he took up the screen close to him, close to his eyes, and this was done to avoid the crowding of the words. It was a very simple sentence of 3 words saying I am late, but even that was difficult for him to read together. So he takes the screen very close to him and tries to read one word at a time, and which helps in magnification, and he can see it himself and read better way. So again, one more example. So this child is with CP and has an inferior vision loss. And so the patient is very, very intelligent. She understood that by sitting down, she could see the TV better. So she refuses to sit on the sofa and goes close to the screen and starts seeing the television. They also look, and there's also possibility that they would look down, like a chin down while walking, as they can't see their feet or ground while looking straight. So this is also a marking or an observation that you can make for a child when the child walks into your clinic. So level 3. In this children, the children will require environmental modifications to be made by you, and then they slowly get adapted to them by getting used to it. So this includes environmental adaptation, includes better lighting, then to optimize the size of the image. Reading desk should be placed in the correct visual field. Like if the child has left side hemianopia, do not place the reading desk on the left side. Similarly, the food on the left side of the plate may miss. So these observations you should make frequently, and then you'll understand that you shift the food to the right side of the plate. Then third is like you have magnification of visual tech devices. So this, and in after doing all these modifications, children use their visual functions in more consistent way and do not require other sensory modalities like touching or someone calling out the name or some sounds to gain their attention. So this is an example of a child who's doing the puzzle game, and to increase the contrast, there is increased lighting which is being done. This is one more example where where in order to increase the contrast, there are black and white strips, striped pillows which have been used for allowing the child to pick up the balls, the green colored balls on them. And yellow and blue also provides a very good contrast background. This is an example. So this child was finding a difficulty in reading the whole sentences. So he was using fingers on the book, like to see one word or one letter. And what we could do is give this CCTV cameras or give this mobiles and magnify that, and read one word with a magnification provided inbuilt. And so the crowding of letters can be decreased and the child will be able to read better. Level 4. So it includes level 3 of environment adaptation and modifications, but the vision is restricted and it is inconsistent. That means the child can perform only part of the vision related activities and also requires other sensory modalities. Example, it means the child shows discontinuous eye contact, uses auditory or tactile stimuli to recognize object or faces. So I would give you an example. This video is being provided by Dr. N.M. Sudha. So look at the child. The child is not interested in the lighted object in front of him. Mother is calling out his name and asking him to look at it. And then he suddenly looks at the chain, but he is not ready to follow it completely when the light is closed or light is switched off. So so there is use of auditory stimuli as well as a bright target, but there's an inconsistent use of vision in this child, and fixation is also not continuous. Here, the child may have a ventral stream dysfunction in which they are unable to recognize faces and objects. So they use their touch. They touch the face of the mother, they touch the face of their friends or the objects and start recognizing. So vision, otherwise they would not be able to use without using these tactile cues. And they they use their vision only in highly familiar adapted environment. This is level 5. The child is disinterested in their own environment, the same environment, even if it is repeated every day, they do not use their own environment. So this was a very good video done by Children's Hospital, Perth, Australia. I've taken it up from them. And you see the therapist. Okay, so this ball, before I start the video, the ball has a bell inside. And also the therapist is asking the child to touch, or rather making the child touch the ball in order to gain some visual attention. But the child refuses to do so. The therapist is taking the ball very close to the child, but child is not ready to do it, or unable to do it rather. So how far these levels are reliable? Professional to professional is very reliable. Parent professional always comes in a difficulty could be faced, because parents always rate a level higher as they do not give more demanding day-to-day activities. There are few limitations of VFCS as it is relatively a new classification. So it is difficult to eliminate auditory or other inputs while observing every time. Identification in which the child has adapted is also difficult. Every time the different adaptations the child takes in is not necessary an adaptation. It could be just a different behavior on that day. And limitation of motor system could limit ways of adaptation, and also vice versa. Because of all these reasons, the child could be classified at a lower level. So familiarity with the child is very important. One must spend few sessions with the child to identify the level of functioning. And there's further work in progress going on VFCS. They had done all the study on spastic type of CP. So they're trying to classify the levels in other types of cerebral palsy. they included 1 to 19 years of age, children with children in the age group of 1 to 19 years, but there were very small proportion children in 1 to 3 years of age. So now they've started recruiting children in that age group and trying to validify the VFCS on them. And there are so many visual parameters, and condensing all of them into 5 levels is difficult. So they are trying to add in more data and more uh, levels, like more sub levels into it. So the summary: if a child walks in, how would you classify them? So first and foremost, you will ask the child, or you would look for the visual functions, and you would check whether the visual function is present in most of the vision related activities. If yes, does the child need adaptations to use visual functions in more vision related activities? If no, then whether the child is doing any self initiated compensations like head postures or finger pointing. If no, then it is level 1. If it's yes, then it is level 2. And again, if the child is using adaptations, whether you are providing it or whether with some technological devices, if yes, then it becomes level 3. If the child is not doing any function or not able to do or consistently the visual functions in vision related activities, so if the answer is no, then you say whether with environmental modifications or sensory modalities, if he is able to do at least partly. If yes, then it becomes level 4, and if no, then it is level 5. So what is the counseling that you would do? It is, first and foremost, we all have to understand it is a fluid state. As the cognition develops, the visual needs will change, so the level may move up and down. So it is very important to not have over expectations. Counseling about need for initiating adaptations, environmental modifications will help us make the best use of available vision. So I have just given a few examples of intervention strategies, but a proper vision assessment by a vision specialist is must before starting any interventions, as there may be many parameters to look in. So this is a level 5. Most important, before you do any intervention, it is very important that there is decluttering of the working space. So there shouldn't be crowding. It should be a black and white background, preferably a higher contrast background or object. Child will prefer the object with motion or light or any sound to grab the attention. So have a look at this video. It is a black background, a bright object, red color object. You can use yellow as well. And the ball has a sound. So, and the ball is so close to the child that maybe he can do touch as well. So he tries to look at it, but again, loses interest. This is level 5. Level 4, again, declutter the background. So it's important to find the favorite color of the child, because that will again increase the interest. You can show different objects like spoon, plates, clothes, etc. of same color. Increase the attention, fixation, and eye movements. So this is a child who loves red color. So she wears red color clothes, red spoons. Okay, and while sleeping, in order to increase the attention, visual memory, a red color star is also shown to the child, and it can be moved along her visual fields to increase the tracking of the movement as well. This child likes yellow color, and why the light background is given, so that gives more contrast to the child, increases the visual attention. In this, the same, while eating, the mother uses a lighted spoon, so that makes the child interested in eating as well. And also in the food and the spoon, it's very important to use the same plate or the same tray while eating. So, and it should be no pattern tray. So this also helps in forming a visual memory. Level 3, I'm sorry, I don't have any pictures for this, but if the child has difficulty in finding food on the plate, that means there's a lot of crowding. The child is getting confused what to choose and where to choose. So it's important that you avoid pattern plates. Use plain plates, like white colored plain plates. Avoid sauces in which there is mixing of the food and they are not able to identify the contour of the food. Divide the food portions. If the child misses the food on particular side of the plate, say inferior field vision loss, and he's not able to see that side of the plate, then turn that side of the plate and see if the child is picking up the food. That will also help you to understand that maybe he's avoiding all the um, uh, all the activities on the inferior vision or the lower field vision. Sometimes there could be problems with floor boundaries, steps, and uneven surfaces. The mother would complain that whenever the surface becomes uneven or there are steps, the child freezes and does not move forward. So in this, first and foremost, avoid patterned floor surfaces. So it could be a clean tile, like a, or if the tile work is already been done, use carpets, like clean, same single color carpets, no patterns and no colors. Mark edges of the stairs with preferred bold color. So if he prefers red color or yellow color or even orange, mark those colors, mark the stairs with those colors. Good lighting is very important, which again increases the contrast and thus the contours of these surfaces will become more evident. Tactile guides to gauge the height of the ground could be present. So if the child is holding the mother's shirt or kurta while holding the while walking, he may pull the kurta down or the shirt if he thinks that the if he's not able to gauge the next step, maybe because there is a step on the surface or it's an uneven surface. And approach obstacles with look, slow, check, go. That means you look first, so look down. Okay, make your steps move slow and then move slowly in the same line. Like they would not change their directions. Changing directions makes them anxious. So this child, he has inferior vision loss, so he's going upside down on the slide. And there's one more example: when a child wants to navigate through a hallway and there are a lot of people, so he would wait and take a pause, find an object of favorite color. So say a child in front of him is walking with a yellow color bag, so he would focus on that and not pay attention to the other people around, and through which he'll be able to navigate further, and that makes his life more easier. So the confusion gets decreased and searching or the visual search becomes less. Example 3, he tries to recognize known faces in photographs by zooming in. So now it is an era of digital media. So if he sees the photographs in a camera or in a mobile phone, he would zoom in first, try to find the mother, where he finds, I know the mother, I know this face. He feels happy, and then he maybe try to zoom for the other people or other relatives. So thank you. I have tried to cover the levels in my best possible way, and I'm still myself working on the levels. So cerebral palsy slows me down, but it ain't stopping me. Thank you. And